Today and tomorrow, I want you to focus on pharmacy law. Pharmacy law is a huge topic, and it's extremely important for the GPhC registration assessment. If you look at the framework, there are many different aspects and learning outcomes relating to pharmacy law. And that's why we have 2 dedicated modules to pharmacy law on the MicroPharm platform. I want you to watch both of those modules. One is called Introduction to Pharmacy Law, and one is called Medicines, Ethics and Practice. I'm going to name the videos that I want you to watch over here. One being Introduction to Pharmacy Law, the second one being Legal Classification of Drugs, another being the Sale of Human Medicines, Prescription-Only Medications, Controlled Drugs, Veterinary Medications and Disposal of Medications, and Information Governance. And here's the names of all of the Medicines, Ethics and Practice videos over here, which I want you to watch for today. I will include some of these for free in this video.
Hello and welcome to an introduction to pharmacy law. My name is Zara and I'll be talking you through some key concepts that concern pharmacists and the law. So in this series of videos, I'll cover the GPhC registration assessments for foundation training pharmacists, the law that concerns pharmacists and a background of the law, the legal classification of drugs, emergency supplies, prescription requirements, veterinary medicines, the disposal of medicines, record keeping, and confidentiality and consent. So there's quite a lot of law that concerns pharmacy, but we'll go through each one in sufficient detail. So the GPhC registration assessment, the GPhC produce a framework every single year that tells you exactly what they're going to cover in the registration assessment. And some of the key outcomes that concern pharmacy law are the ones in front of you. So the first one is supply of medicines safely and efficiently, consistently within legal requirements and best professional practice. So that's more for humans and veterinary medicines. It's a medium weighted topic, so quite important that we get to grips with that aspect. The second one is disposal of medicines safely, legally and effectively. That is a low weighted topic, but again can come up in the exam, so very important that we know how we're disposing certain populations of drugs, controlled drugs, sharps items, etc. Analysing prescriptions for validity and clarity, that concerns the professional requirements as well as the statutory requirements for prescriptions. That is a medium weighted topic again, and again can come up in the exam. And then you've got record, maintain and store patient data, which is predominantly concerned with information governance and the laws of confidentiality and consent. Now, the law in pharmacy, let's just go through a little bit of background about the law. So the law is essentially in the UK, we've got the legal system that is broken down into 2 key areas. You've got civil law, you've got criminal law. Pharmacists can be involved with criminal law if they have a patient harm that results in a death or something or the other that occurs. However, majority of the law that affects pharmacists is civil law, and the key laws that affect it are negligence, defamation, nuisance and trespass. Particularly the law of negligence, that's a very important area of law that concerns pharmacists. I'm not going to go into it into much detail today, but if you are interested in learning a little bit more about negligence, then definitely look up the Bolam test, and the case of Donahue and Stevenson gives us a very good background as to the law of negligence. Now, the key laws that affect pharmacy, there are more laws that affect pharmacists. These are the key ones that we're going to discuss today. So you've got the Medicines Act of 1968, which is more of an enabling act. And essentially what that means is this act gives government bodies the power to do certain things relating to pharmacy. So the Medicines Act in particular gives the MHRA their powers to be able to license medicines, put them on the market. You've got the Human Medicines Regulations of 2012. That is essentially broken down into 2 parts. So part 1 talks about the different types of medicines and the general provisions of a medicine, definition of a medicine, etc. And then part 2 concerns the administration of medicines. The Misuse of Drugs Act of 1971 is more about the prohibitions of medicines, particularly for controlled drugs. So supply, manufacture, import and export of controlled drugs. Whereas the Misuse of Medicines Regulations of 2001 concerns when it can be provided. So a controlled drug, when it can be manufactured, imported, exported, supplied. It also does cover quite a lot about safe custody regulations for controlled drugs. You've then got the Data Protection Act of 1998, the Freedom of Information Act 2000, and the Data Protection Act of 2018, which concerns the law of GDPR. Those three laws in particular together concern information governance, the laws of confidentiality, consent, things like that. The Equality Act of 2010 concerns protected characteristics, allows pharmacists to be able to provide patient-centred care without discriminating their patients. And then you've got the Environmental Protection Act of 1990, which concerns the destruction of medicines, particularly out-of-date medicines and patient returns. And the drugs and the licensing of them is predominantly falls within the MHRA's role. So like I said, the Medicines Act of 1968 gives the MHRA their powers and allows them to regulate medicines and medical devices in the UK. They ensure that the products are safe and that they work, and they use a licensing system before a medicine can be marketed. Now, bear in mind that a medicine or a drug needs to have a marketing authorization. It needs to have a license before it can be marketed. And those are called marketing authorizations. So it cannot be prescribed or sold unless it has a marketing authorization, which is given by the MHRA. Now, the licensing of drugs, there's three key aspects. So when the MHRA are looking at a drug, they look at three key aspects to ensure it's safe, effective, and it's of a quality. So is it safe for its intended use? Is it effective? So is it working as it's supposed to work? And is the medicine product meeting the standard quality? Okay, and you'll have seen SPCs in your undergrad and in your foundation training year, but they are basically a summary of product characteristics, and it's a simplified version of a marketing authorization, and it essentially gives us enough information to allow us to make clinical decisions about patient care, but also to provide information to patients. And it covers quite a lot of things, including indications, dose, adverse drug reactions, side effects, pharmacokinetics, pharmacodynamics of the medicine, storage requirements, etc. So it's really important that you get to grips with how to use that as well for your exam. And the MHRA, not only are they responsible for the licensing of medicines, they're also responsible for many other things. So they've got lots and lots of jobs. And one of those is the yellow card scheme. So as a pharmacist, if a patient presented to me with an adverse drug reaction, it would be my duty to report that through the yellow card scheme. But once that's reported, that ends up with the MHRA. So they're responsible for collating all that data and making decisions about whether a product is safe or not, as well as providing advice on what to do. The MHRA are also responsible for provisions of a manufacturer's importer's license, as well as a manufacturer's specials license. And they also provide rules for the sale, supply and administration of medicines for specific healthcare professionals, advice on when products should be prescribed by brand, wholesale distribution of medicines. They also produce a list of drugs that cannot be parallel imported, and they also provide advice on the expiry of medicines. So as you can see, they've got a vast role when it comes to pharmacy legislation. And it's really important that we understand what they can do and how they get their responsibilities. So now let's talk about prescription-only medicines. We'll look at prescription requirements, we'll look at private prescriptions, and we'll also look at controlled drugs. So generally, the requirements for a prescription-only medicine include the following. You need to have the signature of the prescriber. It needs to be in indelible ink. But it can also be an electronic signature. You also need the address of the prescriber, so that needs to include the appropriate practitioner's address. So it's usually a surgery where they work at or a hospital. And then you've got the date. So the date of a prescription only medicine. So a prescription is only valid for 6 months unless it's a controlled drug. So schedules 2, 3 or 4 are only valid for 28 days from the date that they are written. And for private prescriptions, the appropriate date will always be the date from which they are signed as well. The validity again is also 6 months unless it is a repeat private prescription. You've got number 4, which are the particulars of the prescriber. So this will indicate the type of practitioner. So it could be a medic, it could be a independent prescriber. That will allow you to then check the registration status of that particular prescriber. You then need to include 5 and 6, so your patient's full name, their address, and number 7, their age or date of birth if they are under 12 years of age. Now, a prescription-only medicine, it does come in different types. There are lots of different forms and different colours, and you can have a look on the PSNC website to familiarise yourself with the different types of prescriptions. Repeat slips are not prescriptions. It will only tell you what medications have been prescribed for that patient previously or which ones they can order from their GP surgery. Installment prescriptions are single prescriptions that are dispensed in several installments. So, for example, you might get a prescription for 28 diazepam tablets, but the installment prescription tells you can only give 1 tablet a day to that patient. You've got the NHS repeat dispensing service, where a prescriber can actually specify the number of prescriptions they want to be issued in a batch to be dispensed at several intervals. It's usually given to patients that have that are pretty much very stable in their care, and they're usually issued in batches of 6 or 12. And then the patient will then be reviewed by their prescriber, and then another batch will be issued after that if needed. Private prescriptions do have the same requirements as an NHS prescription. So if you scroll back and have a look at the general requirements for a prescription-only medicine, the same requirements apply to a private prescription. However, a private prescription can be repeated. So if a private prescription had a quantity of 28 and underneath it said repeat, that means you can dispense it for a total of 2 times. If it's an oral contraceptive, you can repeat it 6 times. So in total, dispensed 6 times. A repeat prescription doesn't apply to a controlled drug, which is a Schedule 2 or 3. There is a specific form that needs to be filled out. However, you can do it for Schedules 4 and 5. So if it's a prescription-only medicine and a Schedule 5, the first dispense has to be done within 6 months. The rest of the repeats, there isn't any time limit on that. A Schedule 4 controlled drug, the first dispense of that must be in 28 days. But again, the repeats, there isn't a time limit on those. When it comes to Owings, if you are out of stock on a particular drug or you don't have enough on that day, you can give your patient an Owing. It's usually on a slip. It's sort of like an IOU. You might give your patient, say, 5 tablets on the day because that's how many you had on your shelf, but you still owe them another 22 tablets. So you'll give them a slip to say you can come back tomorrow, the day after, or we'll let you know when it's available for you to collect. But Owings also have a expiry date. So a prescription-only medicine and a Schedule 5 controlled drug, Owings last 6 months from the appropriate date of the prescription. Okay. If the prescription was for sodium valproate or an oral retinoid, the supply of the Owing can exceed 7 days if the PPP checklist is followed. The PPP is the Pregnancy Prevention Program. Patients that take oral retinoids and sodium valproate must be on that program in order to get the medicines, because taking those 2 types of drugs can be teratogenic and harmful to an unborn baby. So it's very important to check that with your patient. For pharmacy lines and GSL medicines, it's 6 months from the appropriate date. And for Schedules 2, 3 and 4, it's 28 days from the appropriate date. So if it exceeded that date, that prescription would be considered to be out of date and you would not be able to give the Owing remainder to that patient. A prescription-only medicine can be provided by dentists and nurses. We'll look a little bit at forged prescriptions, prescriptions from other countries, and also military prescriptions in a little bit of detail. So a forged prescription. A couple of things you need to consider. Forged prescriptions usually tend to occur with private prescriptions or handwritten prescriptions. So you would need to consider the quantity. If it's a large quantity of a drug that is usually misused, that would be a red flag. You'd think, okay, I need to question this. You'd also need to consider, do you know the prescriber? So if it's a prescriber that you know regularly, you see a lot of their prescriptions, you can compare signatures and scrutinize that. You can also contact the prescriber. Now, the key thing is the number that's on the prescription should not be the source you use to contact the prescriber. You can use the internet or a address book of some sort to find the details to contact the prescriber. Do you know the patient? So if you know the patient, it's easier to know whether the prescription's forged or not. Is there a title present for the prescriber? Look at the patient's behaviour. So we already discussed erratic, impatient and aggressive behaviour. That is also something to look out for when it comes to forged prescriptions. And is the medication commonly misused? Is it a controlled drug? Is it a drug like pseudoephedrine, ephedrine, something that we know is misused by patients? Those are the things to consider when we are supplying medicines that could be from a forged prescription. Dental prescriptions are usually on yellow forms if they are prescribed on the NHS. If they are prescribed on the NHS, the dentist needs to be able to only prescribe the drugs that are within the dental prescribers formulary. That's in the back of the BNF if you want to have a look on a paper copy of the BNF. One of the key things for dentists is they can write a prescription legally for any prescription-only medicine on a private prescription. But if they are prescribing on the NHS, it can only be within the dental prescriber formulary. But it must be within their competence. So even if they're prescribing a private prescription for a drug, it has to be within their scope of practice, which is dentistry. You wouldn't expect a dentist to be writing prescriptions for heart conditions or the treatment of epilepsy. It would be related to oral conditions. Nurses can also prescribe within their scope of competency. You usually find them on a lilac prescription for community nurse practitioners, and they also need to follow a formulary if it's a prescription-only medicine using an NHS prescription, which is also at the back of the BNF if you want to have a look. You can also access both the dental prescribers formulary and the nurse prescribers formulary on the online version of the BNF as well if you wish to have a look through those. Your duties as a pharmacist when it comes to the professional and clinical checks, part of your legal checks would be, is the medicine prescribed within the formulary? Because these types of prescriptions are usually handwritten, so at that point it would be a very good thing to check. Usually most dispensing systems are quite good at catching on whether a drug that's been prescribed is within the formulary or not, but human error can sometimes occur and you might not pick the right form or the pharmacy system. So as part of your professional check as a pharmacist, always check the formularies that are appropriate for that prescriber. Prescription-only medicines can also be prescribed from EEA or Swiss practitioners. The prescription requirements that exist in the UK also apply to those prescriptions. They are legally acceptable even if it's in another language, but you must be sufficiently satisfied that you know exactly what that prescription is saying. So clinical judgment is a big factor that comes into account. There are things you haven't got access to. You won't have a patient medication record. You won't be able to look at the patient factors that exist for that patient, particularly if it's a medicine that isn't available in the UK. So it's really important that you consider all of the professional and legal aspects when it comes to a prescription from EEA or Swiss practitioners. There isn't an international database for prescribers, so it's really important that you check the GMC or the GDC website for the competent authorities for EEA. That will tell you who you can contact to find out if this prescriber is a registered practitioner in that country. If it's appropriate, so for example, like I said, if that prescriber has written a prescription for a medicine that isn't available in the UK, at that point it actually might be appropriate to refer them to an appropriate prescriber in the UK. It is well within your remit to refuse to supply a prescription that you do not understand. So if it is in another language and you don't understand what it's saying, it's better to refuse the supply and safety net your patient so that they're able to be seen by a healthcare professional. You don't necessarily have to supply the medicine if you don't deem it to be appropriate. Military prescriptions are not commonly handled in community pharmacies. They're usually handled in military primary healthcare, medical centres. They both prescribe and dispense the medicine, and they are seen on an FMed 296 prescription form, computer generated, but you don't tend to see them a lot in practice. But if you do, then this is what it's supposed to be. You're supposed to have it on a FMed 296 form. Controlled drugs, though, for schedules 2 and 3 have to be written on an FP10 CD, which is a pink form. So when you're supplying a prescription-only medicine, particularly a private prescription, there are labelling requirements for any type of prescription. Private, EEA or Swiss NHS prescriptions, you need to have the name of the patient, the name and address of the supplying pharmacy, the date it was dispensed, directions for use, and any precautions that are relating to the medicine. So it could be something like take the medicine 30 minutes before any caffeine or food or any other drinks or any other medicines. They all need to be on that label.